Hi, everyone. Welcome to another episode of Sarcoma Sisters. So today we are so excited because we have Dr. Catherine Janeway with us today. And so first of all, Dr. Janeway, I'm just going to give a quick intro. Your full bio I'll read out when we record the intro. But Wendy and I both know Dr. Janeway well. She's amazing. And she's a pediatric oncologist and a senior physician at Dana-Farber, Boston Children's Cancer Center and Blood Disorder Center. Her research focuses in genomics and precision oncology and specifically bone sarcomas. And we're going to talk to you about all that today. She's the chair of the COG Bone Tumor Committee, which includes the Osteosarcoma and Ewing sarcoma. But today we're going to focus on osteo. And she is a world-renowned expert in bone tumors. So we just feel so thrilled to have you. I don't want to leave out that you're a fierce woman leader. We love having women leaders on this podcast. So yay. So welcome.
Well, thanks, Lisa and Wendy, for having me. It's great to be here.
Awesome. And so to start off, we're just going to have you tell us your story about how you got into pediatric oncology initially, and then what led you to sarcomas.
All right. Well, I don't know how far back you want me to go,
but I guess it's okay.
All right. Let's see. So I'll tell you about how I got into medicine, and then I can tell you how I got into pediatric oncology. So actually, I come from a family of doctors, and you know, I didn't really think much about the sort of family lineage when I was growing up, but I did think about, you know, whether or not I wanted to have a science-related career growing up. And both my father and stepmother were immunologists, and they used to talk about immunology all the time at home, in the car, went on long car trips, or at the dinner table. I found it incredibly boring, and I said I was never going to be a scientist. And I also have to admit, I might not have been the best high school science student. And so again, I thought I would not do science. But then in college, I studied environmental science and political science, and became, in the course of taking my environmental science classes, became interested in science. At the same time, I was bartending as my college job, and decided I really liked working with people. And so, believe it or not, I got into medical school, even though my essay described how I was inspired by my bartending job. So I'm not sure that would work. Yeah. So anyway, in medical school, I had a really great pediatrics rotation on the service that had the hematology patients on it. I had a really fantastic attending and resident team, and really became inspired by that experience to go into pediatrics, and then pediatric hemonc. In terms of why hemonc, during my pediatrics residency, I realized I really liked working with sick patients. And those of us who like working with sick patients, who are pediatricians, usually look at three specialties: ICU, hemonc, and the ED. So yeah. As I've interviewed people for hemonc residency, that's usually what I hear. And of all of those, it was, you know, oncology gives you this really nice balance of kind of longitudinal relationships, but not forever relationships. So not like a general pediatrician, and also, you know, really interesting sort of science and translation between the bench and the bedside, and then, you know, taking care of sick patients. So that's how I ended up where I am.
That's awesome. And thanks for sharing that story. Yeah, I never realized all that. It all started with the bartending.
All started with the bartending. That
propelled you forward, I would say. I bet you make a mean drink too for St. Patty's Day today, everyone. That's why we're wearing green.
That's right.
That's great. And then what got your interest peaked in sarcomas?
Yeah, so as I was doing my PEDS-HEMONC fellowship, as many of us experienced, I had a couple of very engaging patient experiences with various patients with sarcoma. Specifically, I had a patient with osteosarcoma, and at that time, had to sort of refresh our standard kind of approach to osteosarcoma, what we were using as our sort of reference for our standard treatment plan. And in doing so, recognized and understood how little had improved for osteosarcoma patients over many decades. And then, or several decades at that time, now many decades. And then I also took care of a patient with gastrointestinal stromal tumor, or GIST, and became quite interested in everything that was happening in the GIST field with regards to precision. At that time, you know, very few patients had the opportunity for precision medicine, but GIST patients did. But we understood so little about GIST that occurs in younger patients that we didn't really know whether that was a reasonable approach for the younger patients or not. So those two patient experiences, and then just sort of, I had the feeling that in leukemias, while there was still a lot of sort of iteration to be done to improve outcomes, a lot was already understood, whereas in sarcomas, there was still, you know, a lot to be learned.
Yeah, thanks for sharing that. That I think, like you said, that resonates with, of course, both of us too, on so many levels for all of us. Yeah.
I see you, Edie. HEMONC. Check, check, check. That's funny. Yeah, I don't know if I've interviewed enough people to see that common theme, but for sure, that's sort of what I went through.
Yeah, it's a pretty common theme in people who apply for PED-CMONC fellowships. It's, you know,
awesome.
they like, you know, we like pathophysiology. We like to see, you know, what we can do to sort of to understand exactly what's happening with patients. I guess the other thing about HEMONC is that you take care of the whole patient. So you sort of take over that primary care role and you have to figure everything out. So I like needing to continue to understand different, you know, all the different systems. And although we use our specialists, we sort of have to understand and synthesize all of those different subspecialty opinions. So yeah.
For sure.
So I was going to say, oh, Wendy and I always look at each other like, who's talking next? One other question that could, of course, lead us into a million. But I know that you have your own lab, the Janeway lab, and I didn't know, maybe to start kind of talking about genomics and precision medicine. Can you tell us a little bit about what your lab does and how you relate it to osteosarcoma?
Yeah, that would be fine. So actually, let's see. So the lab now works in a couple of different areas. So the focus of my group for the last, you know, I guess now 7, 8, 9, 10 years has been on precision oncology and pediatric solid tumors. And we really have focused for quite a while on understanding the clinical impact of molecular tumor profiling or other types of sequencing or molecular assays on patient care and patient outcome. So that's been the primary focus of the group. To do that work, we have primarily run or participated in several sort of prospective cohort studies where we sequence patients, you know, interpret that sequencing data in terms of its impact on diagnosis, prognosis, and therapy, and then follow sort of what happens to the patients, follow their cancer journey in terms of what happens with treatment and then response to that treatment. So that has been the primary focus of my group. We also work on projects to better define the sort of genomic features of pediatric sarcomas with a focus on osteosarcoma, but also looking at all pediatric sarcomas. We have worked on, since the RACE Act came out, we have done a couple of projects, and those are actually being presented at AACR in a couple of weeks, trying to look at sort of opportunities for precision therapy in pediatric cancer patients. And then more recently, because we now have, you know, generated genomic data on sort of about over 2,000 patients, and we're interested in making that available and, helping people understand pediatric cancer better through that data. We've sort of backed into a little bit of work on data science, or kind of how you make clinical data from the electronic medical record more analyzable, more like genomic data, how you can make that clinical data kind of compartmentalized and standardized. And that's coincided also with the Childhood Cancer Data Initiative. So we have a project with the CCDI, or Childhood Cancer Data Initiative. So those are the areas that we work on. I mean, it all falls under the umbrella, I think, of precision oncology and genomics. And we definitely focus on pediatric solid tumor and sarcomas.
I think I get asked this question a lot, and I think probably you are probably the better person to answer it. But, for our listeners, which I think Lisa probably knows our listener audience better than I do, but it's mostly patients and families and, parents of people who've been diagnosed with osteosarcoma. And it's no secret. I mean, if you just Google osteosarcoma therapy, we know it's old as stink. It predates probably all of us on this call, and it's 3 drugs. It's methotrexate, cisplatin and doxorubicin, plus minus the methotrexate if you're older. And so thinking about just the way that osteosarcoma is similar and different from other pediatric sarcomas, with, the genetics of it or the genomics of it being sort of all scrambled and mixed up, and your work in precision oncology. I mean, I probably, especially if I go home to like my family, I get this question over and over and over again. And is precision oncology going to be the singular answer? And I think for some cancers, it could be. But where does that stand for osteosarcoma? And it's just been this black box for so long, even though we continue to learn so much more about it. What do you think is the future of precision medicine for osteosarcoma? Super easy question to answer, right?
No, it's an excellent question. So a couple of things. So precision oncology won't be the answer for every cancer. It's, let me answer the first part of your question, and then I'm going to answer your question in 2 parts. The first is to talk a little bit about precision oncology and kind of, I don't know, for lack of a better word, like fads in science and medicine.
Yeah, for sure.
And then I'll talk about precision oncology and osteosarcoma. So the first thing is, none of the new things that come along in science or medicine are going to be the answer for everything. And there's always a lot of excitement about new things, because for some cancer types, they can be transformative. And then for some cancer types, we can add them to what we already do, and they become just another part of our armamentarium, of our kind of weapons that we use against cancer. So, precision oncology of our lifetime in science and medicine, the 3 of us, precision oncology was kind of the first one of those that came along, right? And I think a lot of us got very excited, and it has been the answer for some small subset of cancers. So, and those, just the data that's emerging and is really, again, we're going to be talking about this at AACR coming up. It is the answer if you have a fusion, an activating fusion kinase oncogene, right? It is the answer. So if you have an NTRK fusion, it's the answer. It's what you need. You need that and maybe surgery, and that's probably it. That's probably all you need. So there's some small subset where that's absolutely right. There's going to be a group of cancers where precision medicine, or what we think of as sort of molecularly targeted therapy, that's based on like one gene alteration that you find, where that plus chemotherapy will really improve things. So the first example of that is probably really in the leukemias, where we're seeing that, but we know it's being studied in neuroblastoma. So anyway, that's that. Then the next one that came along was immunotherapy, i.e. immune checkpoint inhibitors. Unfortunately, in pediatric cancer, that's probably not the answer for almost anything except for maybe, lymphoma. And then, now we have CAR T cell. And CAR T cell, I think we're in the middle of trying to figure out, for whom that will be the answer. At first, it looked like it would be the answer for everything, for everybody. Now we're learning, even in the places where it works, it's probably doesn't last forever for everybody. So Anyway, just to say, there are fads in medicine, and when they first come along, we always think they're going to be the answer for everything, and they alone will answer. But then, of course, we know cancer is smarter than that, and it's an answer for a small subset. It gets added for another subset. It doesn't work at all in some other group of people. Okay, so that's the answer to the first question about precision oncology, and is it the answer? I'll say one other thing about that. The difference between precision oncology for me and genomics for me, and is it, and then I'll promise I'll talk about osteosarcoma, is that now to me, it's now like pathology or the diagnosis. Like, we really shouldn't be practicing medicine for a patient without knowing what the genomic makeup of their germline for most patients and their tumor is, because it's just another piece of information that I think we should understand about that patient and their cancer as we care for them. So to me, that makes genomics or molecular tumor profiling maybe a little bit different than something like, immune checkpoint inhibitors, immunotherapy, or CAR T cells. I think it has to remain, even for those diseases where it might not be the answer, I think it needs to remain a part of what we understand about their cancer. I'm not sure everyone agrees with me about that. So that's sort of a controversial statement. Okay.
Your hot take on genomics.
That's my take on genomics. I mean, but I'm obviously biased. I practice in an environment where we do have that information for every patient. It's true, we don't know how to make sense of it for every patient in terms of their treatment right now. But if we don't have that information, then many times we're kind of operating with only part of the picture. We have the pathology, what someone looked at under the microscope. We have the stage, whereas the cancer, but we don't understand kind of fundamentally underneath what's driving the cancer, what's making it abnormal. So anyway, that's my belief. Okay, so then osteosarcoma and precision oncology, which is really the question you asked me. So what we're mostly focused on right now in osteosarcoma is the following. So if you think about other cancers that we treat, leukemia, the most common example in childhood, now gliomas in childhood gliomas, or childhood medulloblastoma, or something that people are a lot more familiar with, breast cancer. When someone tells you, I have breast cancer, the next question that gets asked, even if you don't know anything about breast cancer, like you're not a breast cancer oncologist, is what type of breast cancer do you have? And the type depends in part on the stage, which is important. But the most important information for what type of breast cancer is a couple of kind of features that are associated with why the breast cancer is growing and dividing and how it responds to treatment. So there's HER2 positive breast cancer, there's estrogen receptor positive breast cancer, there's triple negative breast cancer. So there are these, and then there's BRCA mutant breast cancer, right? There are these like 4 types of breast cancer. And actually most cancers now have these different subtypes. We treat osteosarcoma like it's one disease. I am certain it is not one cancer. I am certain that there are subtypes. So what we're really focused on right now in precision oncology and osteosarcoma is first defining the subtypes. And the subtypes, what we use right now for osteosarcoma to define subtypes are observations of its behavior. Is it metastasized? What's the % necrosis after chemotherapy? Those don't help us make progress, okay? They don't help us understand. They've already happened, first of all, when we observe them. And secondly, they don't help us understand kind of what's driving the cancer, what's making the cells divide, what's making it go other places. And we have to get to a point where we have subtypes that are what we call sort of molecular subtypes that are associated with treatment response and resistance. We have got to get to that point with osteosarcoma. It is feasible to do that now. One of the reasons we haven't understood subtypes till now is because of what you were describing about that, like, Wendy, you were talking about that what we call it complex genome, meaning the looks like an egg beater went after the DNA in the osteosarcoma, right? And so we haven't been able to read that kind of abnormalities in the DNA with our molecular tumor profiling or our sequencing. But now we can. We now know how to do that, and we can do it with the types of materials that we are able to get from patients. And all we need to do now is get a lot of patients together to agree to let us have access to their tumor tissue, their blood or saliva samples, and their medical records. And if we can do that, and we can get the funding we need to sort of do all of the sequencing that's required, which in osteosarcoma requires whole genome sequencing, then I am certain we will define molecular subtypes. So that to me, so that's the first step. So you don't start to try to do precision oncology in breast cancer until you define the subtypes, because the subtypes help you understand what are those sort of gene features that are then potentially targetable by molecularly targeted treatment in each of the subtypes. So that's kind of, that's what I'm feeling pretty passionate about these days, as you can tell.
I remember you talking about this a couple of years ago. It was all when we could be together in person, and you had just taken over the bone tumor committee. But I think what you bring up is so important. You know, people know what the BRCA gene is. People know what cancer predisposition is, and they know certain things about other parts of their genetics. And we don't have that same sort of common terminology or understanding about certain pediatric tumors. And some we are learning more about, but this one in particular, we don't have that. And so it's fascinating. And I think, you know, even just thinking back, I haven't been doing this terribly long, but now it's, you know, a decade, I guess, which is long enough, you know, and I do see even in my own practice, things shifting from what, when I was a fellow, seemed sort of like a pipe dream where we would send genomics on everyone or most people. There was a lot of skepticism about it, you know, back in the early 2000s or even mid 2000s, really. And now it's becoming something that I'm so much more comfortable with. And, you know, there's commercial places that can do it if you're not at a Dana-Farber or, you know, a Mayo Clinic. Like there are ways for physicians to get this information, and trying to sort through what we do with it is a whole different ball of wax, but that's on us. That's not, you know, on anyone else. But I think those are all super interesting points that we are starting to learn more and more about our own genome, our own germline from people with cancer, without cancer, other diseases. And this just has to fall lockstep with that. Mm-hmm. That being said, sort of this underlying project, which I know has been your passion and your baby since you took over the bone sarcoma committee, of trying to get these subtypes figured out, this sort of dream project that you talk about doing the whole genome sequencing for osteosarcoma. Do you anticipate that to be a multi-site retrospective action, because going forward is a bit challenging in terms of number, time, et cetera, and follow-up?
Yeah, this is a great question, Wendy. So, so we're the way that we're hoping to do this, or the project that I'm involved in, I should put it that way. Let me back up. There are a couple ways to do this. So one way that we've already worked on, and other groups have also worked on, is to take the data we already have from the sequencing that our patients have already had as part of studies, or even as one of those types of tests you were talking about that are from commercial providers. Taking that information that we already have, marrying it with information in the medical record, and trying to see if we can find subtypes that way. Okay. So we've already started working on that. Other groups have worked on that. We can also pull samples that we collected for patients who were enrolled on clinical trials, for example, in the Children's Oncology group. So that's sort of the retrospective look. So we've already done that with our kind of what we call gain and profile cohorts. Those are the two big cohort studies I told you we've been involved in. We presented that at ASCO a couple of years ago. From that work, and also confirmed by work from another group, it looks like having MYC amplification in your tumor, which happens in about 10% of osteosarcoma patients, is associated with more aggressive disease. That type of look at information, that's sort of patients who have already had sequencing and who are sort of from multiple different studies with different methodologies, it has some limitations. There's certain things that are harder to understand with those sorts of studies. And so we need to confirm that finding. So I don't want people to go home thinking, MYC amplification, bad osteosarcoma. There's a lot more that we need to learn about that, but we have this preliminary hint that that may be the case. So we're working on a study of patients who were enrolled on clinical trials, which is a cleaner approach to collecting the information about treatment and how people do on that treatment, because we sort of prescribe the treatment. That work has been a little bit challenging because the samples were banked before we really knew or understood what we wanted to do with them. And bone sarcoma samples are particularly hard to work with in the basic science laboratory. And so we are having some challenges related to kind of getting those tissues to give us the information that we want. But we're working on it, and we'll probably be able to solve that problem. What we're working on most recently are two things. The first is getting a larger population of osteosarcoma patients together, and making sure that that population of patients we get together are representative of all osteosarcoma, not just the osteosarcoma, for example, that we see in pediatric centers or that enroll on COG studies. And we're using a project called Count Me In to do that. Count Me In is it's a collaborative investigator, doctor, patient, family project. It's the brainchild of someone named Nick Wagley, and then very early on, someone named Corey Painter. They created a Count Me In project initially for metastatic breast cancer and angiosarcoma. And the idea behind the project is to go bring research sort of outside of the clinic and directly to patients, right? We access so many things directly now from our phone or our computer. And their sort of brilliant idea was, why can't we make research accessible like that? So that if people want to participate in research, they can just do it without the sort of brick and mortar hospital, clinic, and the barriers that creates. So they're trying to like break down the barriers. And they were incredibly successful in this very rare cancer called angiosarcoma and in metastatic breast cancer. And they've had some really meaningful insights through that work. So we actually launched an osteosarcoma project now right before the pandemic. It's actually one of the last things that I did before the pandemic was to go to the MIB meeting and to see Corey present and to have the team there to sort of launch the project. We have 250 patients enrolled. Unfortunately, the pandemic really slowed down the acquisition of tumor samples, but we do have saliva samples on a number of patients, and those are being sequenced now. Let me talk a little bit more about what the osteosarcoma project vision is going forward. So the vision is basically to bring, as I mentioned, bring the research directly to the patient, to do that in a way that's informed by the patient and parent and participants. So the platform is created with input from an advisory group who are patients, pediatric and adults, parents, bereaved parents, and really kind of help us understand how to bring this directly to patients. So that platform is already created. Then the idea is to bring in medical records and samples, both tumor and germline, which is usually from saliva, but can be from blood. And then to study those in every way that we possibly can, given the limitations of the material that we receive, which usually involves sequencing of tumor and normal with whole exome sequencing, whole genome sequencing, whole transcriptome sequencing. And then the idea is to make that as a resource for everybody, all the clients of the research, right? Which includes the patients and families, participants. It includes investigators everywhere. And so you bring stuff in, you sequence it, and then you make that data available sort of right away. That's the vision of the project. We were able to get a grant as part of the Cancer Moonshot to be part of a team called the Patient Engagement Cancer Genome Sequencing Project. which will allow us to do a couple of other really exciting things. The first is that we're going to study how we engage patients, and we're going to make sure that we're doing it well. And if we're not doing it well, we're going to improve on it. So we're studying, how well and how diverse a patient population we're able to reach. And if it's not diverse enough, if it doesn't represent the sort of full picture of osteosarcoma, who are we missing and how are we going to better do outreach for those people? So that's one exciting thing. The second exciting thing it lets us do is to explore in this direct-to-patient research context, how we can share what we've learned from an individual participant back to themselves, which in other words, for the tumor sequencing, we're going to generate a shared learning report, which informs the person who sent in their tumor, sort of what we found in their osteosarcoma that's helping us learn more about this disease. And then the participants also have the opportunity to opt into meeting with a genetic counselor and having clinical germline testing done and getting those results back. So we have the Osteosarcoma project up and running, but sometime this spring, as long as our IRB protocol which has comments, gets approved, we will be launching the sort of new version of Osteosarcoma project for Count Me In, which will include these other components. And hopefully now that the pandemic, either we're over the pandemic or we've adapted enough to working under pandemic conditions, that we're sort of reinitiating the tumor acquisition process program for this study. Sorry, I get excited about Count Me In.
No, yeah.
The reason I did this is I was like, oh, she stole my question, because
I know
we
we talked about how we were gonna, yes, and we had Corey on the podcast. And
Great!
Yeah, she's so amazing. She's just love talking with her.
Yes.
And I think it is so exciting because I think the patient feels so empowered and the family. It's like they want their information, and I think part of the thing, which we're much better now than like 10 years ago, but is that patients feel like that their doctor might be hiding something from them, or they're not getting the whole picture, and this gives them. It's like you're sharing your samples, but then you're getting so much back. It's not just like we're giving and then what are they going to do with that research? How's it going to help? So I think that's so great. And is it open only in the US, or can patients outside of the US to participate in Count Me In?
Great question. So Count Me In has extended to Canada. We have a limitation that's really a regulatory limitation, not created by us, but created by the laws that sort of govern sequencing testing. We are not allowed to allow people from Canada or New York State to participate in the part of the study where we share back our learnings from the tumor. So that's a little, it is open, but unfortunately that those sort of shared learnings, as we're calling them, are not available to people in Canada or New York State. I want to say, Lisa, I'm really glad that you brought up this point about the patients and families being empowered. It's actually because the patients and families in the osteosarcoma community organize themselves and engage themselves with the investigator and physician community through a couple of different organizations that we were able to get Corey and Nick interested in osteosarcoma. So it's really the empowerment of those groups, which they did themselves, which sort of allowed us to leverage this Count Me In platform. So I kind of, as that patient family kind of network was growing and becoming more active, I was able to go to Corey and Nick, not just me, a couple other people were able to go to them and say, hey, you guys, this is we have great partners in this disease. I think we can do this. So I just want to, give credit to the advocacy, patient, family community for sort of putting us in this position where we're able to, to launch this project.
It's something we've heard a couple of times over now. I mean, Corey was Dr. Painter was one of our first guests that we had on. And I remember the MIB meeting where I heard her talk, and I was like, this is interesting. And it's such a neat project because for years, and the funding agencies and federal funding agencies caught on a long time ago, and this is why this sort of team science has been encouraged, mandated. If you want more money, you got to work together. But it's such a good platform to break down those silos. And I think it's more obvious to me here now that I've moved to the upper Midwest, where Mayo is Mayo, but we're sort of plopped in the middle of a cornfield, if I'm really being honest. And our patients come from places where I grew up, where there's not a lot of access to care. There's certainly not tertiary or quaternary centers every 15 miles like, there can be on the East Coast. So it's just a nice way to break down those silos and provide a lot of information. So they get information back. The researchers, we can query these places or these data banks and get information for our project. So it's just so cool. But the other part that we talked to Dr. Weiss, Aaron Weiss, about, advocacy with the Desmoid Tumor Foundation and things like that. And it's just this, we all know it, but then like when you really start talking about it, how important the patient advocacy has been. And, on one hand, I'm so proud of them. On the other hand, it breaks my heart that they have to do this, that they've really had to be the people that have cared the most out of anyone, because there's limitations of what we can do and whatnot. So I don't know, like I'm like half part, like so stinking proud, and then half part like, gosh, did we let them down? And they had to do this for themselves. But, people do what they have to do. And I think at the end of the day, as physicians and researchers, we've ultimately benefited from it and hope to give that back to them through the information that we learned from them too. So it's just, I think every sarcoma that we talk to, we can find those groups. So it's kind of a cool thread, I guess.
Yeah, very well said, Wendy. I think that's absolutely right, that it's, both great and also, makes me sad that this is required in pediatric cancer, this kind of advocacy, but it's great that there are people there to do it. So
yeah, for sure.
Very well said.
For sure. Go ahead, Lisa.
Yeah, well, I know we don't have a lot of time left, but as the chair of the Bone Tumor Committee, we've been talking a lot on this podcast about clinical trials and just as you mentioned, obviously all this research that you're doing now is going to translate that into the future, but what are you excited about right now, and where do you see us going with clinical trials? And I guess I'll just let you speak, because I could ask a million different questions, but I'll just stop there. Like, what are you excited about? What do you think?
Yeah.
Where do you think we're going? How do we get these done faster?
So I guess I have to focus on osteosarcoma because we don't have time to talk about everything.
Right.
That's sort of what you asked me to focus on. But so for the Bone Tumor Committee, we're really excited about a couple of things. The first is that we have one phase 3 trial open and another one under development for newly diagnosed osteosarcoma patients, which we haven't had in a very long time. So one of the phase 3 trials, which is already open and being opened at centers across the country through the Children's Oncology Group, and is available to be opened at any Children's Oncology Group institution, is a clinical trial trying to figure out what the best approach is to removal of lung metastases from osteosarcoma. And the two approaches being studied are open thoracotomy, where there's an incision in the chest and the lung is felt, or what's called thoracoscopy, which is one of those minimally invasive surgeries that you do with a camera. And so that trial is a surgical trial, and we're really excited about it because people believe there are pros and cons to each of these procedures, but we've actually never proven that through research. And this is our opportunity to do that. It's also an opportunity to obtain really valuable tissue for us to understand more about osteosarcoma. So we've set up this really robust sort of biology research component of the study, so that living models can be created out of the lung tumors that are removed, so we can learn more about metastatic cancer. The other phase 3 trial, which is what we call in development, meaning the protocol is being written, is to evaluate the safety and then how well it works of adding what we call a multi-targeted kinase inhibitor, which is a class of drugs that work well in osteosarcoma that's come back and been resistant to treatment. But we're asking now, does it help us cure more patients if we add it to chemotherapy? So patients will be randomized, meaning a flip of a coin will be used to determine what treatment arm people are put on, to either getting the standard MAP chemotherapy or MAP plus something called cabozantinib. This is going to be available in, I'm going to estimate, about a year for any patient with newly diagnosed osteosarcoma. As I said, there'll be a phase first where we make sure that it's safe to give these medications together. And then if it's proven to be safe, we'll enter this randomized component. one of the things that we're doing with this study is we've built a lot of additional research around the trial so that we come out learning not just about this new treatment, but also better understanding subtypes. So this is like the third way in which we're doing the subtype question, and it's the most robust and sort of rigorous way, which is that we're actually going to test the subtypes on patients who enroll in this prospective trial. We're looking at quality of life. So how is quality of life for people who have osteosarcoma? We have little studies looking at this, but no one's really done a big study of that. So we have this really robust quality of life component. And along with the quality of life component, we're actually also asking questions about food insecurity and other types of stress in terms of access to care or to financial status, and trying to help us understand how that impacts osteosarcoma disease course, because that's a very under-researched area.
That is so exciting. There's just so many, I think, right, you're going to get so many answers from this trial.
Yeah.
And I think it is so important to look at those quality of life items as well. And then, so are the biopsies required to enroll on trial so you can get that information?
It's a great question, Dr. Cobb. We are working towards that point. At the moment, we have not, but we need, if we get enough data from these other studies that we're doing to show that there are likely 2 or 3 subgroups that are associated with how people, do with our standard treatment, like how well it works, then it's likely that we would be able to support required submission of materials so we can sort of finalize or nail down those subtypes with this really good high quality data. So that's what we're aiming for. Whether we'll achieve that is unclear to me. But regardless, people are encouraged. We're working really hard with pathologists and surgeons and interventional radiologists to help them understand how important it is to get small amounts of tumor tissue into the hands of researchers so we can really make progress in this disease.
Yeah, it's crazy. I mean, you said it, but I mean, I think people that listen to this podcast kind of longitudinally sort of know where Lisa and I have been, but I have yet, as an oncologist, had the opportunity to enroll an osteosarcoma patient on a phase 3 trial. It's just not been an option. And so to have options is sort of a new era in my practice, which is nice. So thank you.
And Wendy's way of saying how she's younger than us, but that's okay.
I have not enrolled an osteosarcoma patient in a phase 3 trial. And for people who are listening, like that is essential to making progress and curing more patients. So, we're really excited that this is gonna, hope, we're still a little bit of ways, but so far, everything seems like it's going well.
Cool.
Yeah.
We're out of time, Lisa.
I know. Thank you so much. It's been just so great, and you are an inspiration for so many people, and I am so glad that you're leading the Bone Tumor Committee and all these other projects. I don't even know when you sleep, but but it's so great. So thank you for being with us today and answering all these questions. And I know people are going to find this so helpful. We really appreciate it.
Thanks, Wendy and Lisa. It's working with people like you that makes the job fun. So great to talk to you today.